We present to you a case of ultrasound-guided hysteroscopic metroplasty. This video will demonstrate simultaneous use of pelvic ultrasound and hysteroscopy to resect uterine septum. Septate uteri are found in 1 to 15 per 1,000 women. Both the American Society for Reproductive Medicine and European Society of Human Reproduction and Embryology have developed criteria for diagnosis. The European classification is more specific, requiring a normal uterine outline and internal indentation greater than 50% of the uterine wall thickness. They can be complete to the level of the cervical os or partial, and are composed of predominantly muscle fiber with some fibrous tissue. The gold standard of diagnosis of uterine septum requires hysteroscopy with simultaneous laparoscopy. They can be diagnosed on imaging using three-dimensional ultrasound with saline infusion sonography. This technique has a sensitivity of 100% and specificity of 100%. Alternatives for diagnosis include three-dimensional ultrasound alone and magnetic resonance imaging. Septate uteri are not associated with renal anomalies, but are associated with pregnancy complications including spontaneous abortion, malpresentation, intrauterine growth restriction, placental abruption, and perinatal mortality. A septate uterus does not increase the risk of infertility, but pregnancy rates are improved following resection in women who present with infertility. Some gynecologic procedures are more challenging or contraindicated in women with uterine septum, including non-resectoscopic endometrial ablation and insertion of intrauterine devices. Resection of uterine septum can be performed with laparotomy using a wedge resection or incisional metroplasty. It is more commonly performed with hysteroscopic resection using cold scissors or bipolar electrosurgery. A challenge with hysteroscopic resection is complete resection of the uterine septum. Multiple imaging techniques, including fluoroscopy and ultrasonography, have been explored to increase the success of complete resection. Evidence exists that ultrasound-guided hysteroscopic resection of uterine septum results in decreased need for reintervention. We present to you a case of a 30-year-old gravida 0 who presented to gynecology with abnormal uterine bleeding. Her past medical and surgical history were unremarkable, apart from a body mass index of 52. The remainder of her history and physical examination were non-contributory. She underwent a three-dimensional pelvic ultrasound, which revealed a partial uterine septum. Endometrial biopsy revealed disordered proliferative endometrium. After a thorough discussion of the treatment options for her abnormal uterine bleeding, she wished to proceed with an ultrasound-guided hysteroscopic resection of uterine septum and insertion of levonorgestrel-containing intrauterine system. A skilled assist provided ultrasound guidance during the procedure. Ultrasound was used to visualize the uterine septum prior to the procedure and assist with complete resection. A sweep of the uterus in the transverse plane was performed. The division of the endometrial cavity by the septum was easily visualized. A 2.9 mm operative hysteroscope with a 30-degree lens was selected. Dilation was not necessary to enter the cervical os. Hydrodistension with normal saline was utilized to expand the endometrial cavity for better visualization. The Gynecare VersaPoint bipolar electrosurgery unit with twizzle tip was utilized with settings of Vapor Cut 100 and Desiccate 50. Resection of the septum was performed using a side-to-side sweeping motion with short bursts of energy to vaporize the tissue. Ultrasound was then used to confirm that the septum had been completely resected. As demonstrated, the filling defect that was seen previously was no longer present. The levonorgestrel containing intrauterine system was inserted in the usual method. Placement was then confirmed using hysteroscopic visualization. The intrauterine device was noted to not be an optimal placement, so hysteroscopic graspers were utilized to reposition the device. Once the intrauterine device was in optimal position, the hysteroscope was removed and the procedure was complete. Ultrasonography is a useful tool that can be added to hysteroscopic metroplasty. It improves visualization during resection of uterine septum and has been demonstrated to increase the rates of complete resection. We encourage you to make this small change that may lead to improvements in your clinical practice.